Hi, everybody, and welcome to AARC's Big Ideas Theater. I'm your host, Ed Highland. I'm joined now by Rich Branson. He's one of the experts for Monday's session on using volume control to ventilate a patient with ARDS. Rich, thank you so much for coming by.
Thank you.
Let's dive right on into it. Give us some ideas of what are the limitations of volume control in ARDS?
Well, it's important to remember that the ARDSnet ARMA trial basically showed us that limiting tidal volumes and maintaining lower peak pressures or plateau pressures resulted in improved outcomes in patients with ARDS. So volume control has kind of become the standard of care in a lot of places, but there are certainly limitations. The most important, I think, of which is patient comfort. When we set a certain tidal volume and that monotonous tidal volume is given over and over and over again with no ability to vary it, the patients can become uncomfortable. Just as important is when I set the patient up on the ventilator in volume control, I choose how long that breath lasts, the inspiratory time, and I choose how quickly that breath gets delivered via the flow setting. And there are lots of patients who want more flow than the ventilator delivers. And in volume control ventilation, there's no ability for the ventilator to interact. If I set the volume at 400 and the flow at 40 liters a minute, and the patient wants 80 liters a minute, the ventilator does nothing. It just makes the patient work even harder, requiring more sedation, which has its own long-term poor outcomes.
Can you give us an idea on how close the interaction must be to achieve the proper volumes?
Well, I got to tell you, from a volume control standpoint and what we refer to as Synchrony, patient-ventilator interaction, that the patient and the ventilator are talking together and working together, it's more likely that it happens by chance than you actually did something to make it occur. It's very difficult, it's very challenging, and it is a balance of ventilator settings, sedation, and medications to make the patient have less pain and more comfort.
What are some of the assessment skills that the RT needs to utilize to achieve synchrony?
Well, respiratory therapists, first of all, need to recognize dyssynchrony. What does it look like on the ventilator? What does the patient look like? Use of accessory muscles, the look of fatigue, of air hunger, big eyes, nasal flaring, even though they have a tube in their mouth that they're breathing through. And then assessing the ventilator, the waveform screens. You can tell very easily dyssynchrony from in volume control, because instead of the breath rising very smoothly to a peak pressure, you see it kind of scooped out like this, and that's the reflection of the patient wanting more than the ventilator's delivering.
How are some of the other breath types able to perhaps achieve some of the overcome some of the shortcomings?
So there's a large group of people who think pressure control, or setting the pressure and getting the volume as a variable that's based on patient effort and compliance and resistance, is a better way to go. There was a recent paper by Marcel Amato that showed that in ARDS it's driving pressure. The difference between where you're at PEEP and where you end at the plateau pressure, that determines not only outcome but recruitability of the lung. And it may be easier with pressure control to limit that and keep track of it, and pressure control has the advantage of the flow is set by the ventilator, so the harder the patient works, the more flow the ventilator can deliver. So pressure control gives you an advantage of absolute pressure limitation. It never goes higher than what you said. It provides a variable flow, which allows the patient to not be so air hungry. And the third thing is it makes lengthening the inspiratory time or adjusting inspiratory time to improve mean airway pressure much more simple and less complicated for work of breathing.
What would you recommend to RTs to make sure that they're basically keeping up with the latest on volume control?
So in terms of how you ventilate patients with ARDS, the way to keep up with it is be familiar with the journal. You got to read the journal, you got to see what's being said, you got to look at the journal conference papers that are basically essentially reviews of the state of the art of these kind of techniques. But we all have come to the conclusion after years and years and years of it has to be this ventilator, it has to be this mode. The important thing is at the bedside, whatever it is you do, you use the lung protective approach and you know what you're doing. And after that, it's everything else, regardless of whose machine you use or what you set to that, you'll probably be successful.
So kids, do your homework.
That's right.
Rich Branson, thank you so much for joining us.
Thank you.
And this is the Big Ideas Theater at AARC. I'm Ed Highland. Thanks for joining us.